This program is brought to you by Emory University.
Good morning, everyone. Happy Friday. I'm happy to introduce Dr. Rachel Warnock, who is one of our esteemed first-year fellows, and she joined us she did her med school at Emory and then her residency at Emory, and we were lucky to keep her here for fellowship. And she will be talking to us today about left atrial appendage occlusion. It's all you, Rachel.
Thanks, Dr. Coley. My name is Rachel Warnock. I'm one of the first-year general fellows. I'll be talking today about percutaneous left atrial appendage occlusion devices. And so I have three objectives today. I'll first go over a brief overview of left atrial appendage devices, the evidence for them and indications. I'll then outline post-left atrial occlusion device care, including antithrombotic therapy and surveillance imaging. And then finally, I'll discuss a few complications of left atrial appendage occlusion devices and their diagnosis and management. So starting with the patient case. The patient was a 63-year-old man. He had a past medical history of permanent AFib for a while, since 2012. He had a CHADS VAS score of 4. He was notably on warfarin due to a history of rivaroxaban-induced hepatitis and had adverse drug reactions to dabigatran and was thus deemed not a candidate for DOACs. He had biventricular heart failure. He had an EF that nated around 15 to 20%, and so he had received a primary prevention ICD. His EF at the time of Watchman placement was 35 to 40. He had hypertension, and he had cirrhosis secondary to both non-alcoholic fatty liver disease as well as a previous history of alcohol use, though notably did not have any esophageal varices on surveillance screening. But unfortunately had a history of GI bleed from multiple peptic ulcers while he was super therapeutic on his warfarin. And so due to his inability to tolerate DOAC therapy and high risk for GI bleed, he was referred for a Watchman placement, which he underwent last summer without complication. He was discharged on dual antiplatelet therapy with aspirin and clopidogrel. He came in 6 weeks later per protocol to undergo a planned surveillance TEE, and these are his images. So as you can see, there's about a 1.5 centimeter device-related thrombus in his left atrial, on his left atrial appendage. So based on these findings, the decision was made to restart him on anticoagulation in place of the dual antiplatelet. After discussion with him, the decision was made to do just to restart his warfarin as he had previously tolerated due to his reaction to DOACs previously. So he had underwent another TEE 6 weeks later after being on Coumadin. And as you can see, he had complete resolution of his device-related thrombus. So after talking with him, the decision was made to keep him on warfarin for a total of 6 months post-procedure, which he tolerated well, and then switch him to aspirin monotherapy. And he actually recently was switched in January. He had completed the 6-month course of warfarin, and he is doing well. So now I'll talk about an overview of left atrial appendage occlusion devices. So there are two main devices that are used. One is the Watchman Flex Pro, which is the improvement on the previous generation Watchman 2.5 that has more of kind of an umbrella shaped design. And then the other one is the Amulet, which has more of a lobe and disc design. Each one has their pros and cons that I'm not going to go into today, but they can be used for kind of different indications, but they're both available for use in the United States. So a brief overview of the procedure itself. I took these pictures from the Boston Scientific website. There's a video up there. But this is more specific to the Watchman itself. But basically the first step of the procedure is to obtain femoral venous access, typically through the right femoral vein. Then the sheath, usually a 14 French sheath, is advanced into the right atrium. Under either TEE or sometimes intracardiac echo, a transeptal puncture is then performed and the patient is systemically heparinized. Either a stiff wire or a pigtail is then advanced into the left atrial appendage and the Watchman sheath will follow. And then the newer Flex device has this ball mechanism that allows for safer maneuvering into the left atrial appendage. And then the device is employed. Sizing of the device is done by fluoroscopy or by TEE or preoperative CT. So the evidence for left atrial occlusion device placement comes from mainly three main randomized control trials: the PROTECT, PREVAIL, and PROG-17. And they did show that left atrial appendage closure was non-inferior to oral anticoagulation while reducing the risk of non-procedure related bleeding. And a lot of the data that I'll present today includes kind of a conglomeration of the different generations of devices, but with newer devices, the procedures only become more favorable. Data from the newest generation Watchman device, the Watchman Flex, was studied in the initial trial of the Pinnacle Flex trial that have got the device approved, and then the SURPASS registry that followed patients up more long term. And it showed lower rates of safety endpoints even than the previous trials, as you can see in this chart here. It also had higher success rates, and interestingly enough, in the initial trial of 400 patients, they didn't have any pericardial effusions, and no patients had peri-device leak greater than 5 millimeters. And the safety data was corroborated by the SURPASS registry of 97,000 patients, showing very low peri-procedural event rates, especially pericardial effusion. Additionally, only 4% of patients had a significant peri-device leak that at this time was greater than 3% at 45 days, which is also lower than previous studies. And so the improvement in outcomes with this new device likely comes from, one, that the device is improving itself, but also operator and lab improvement in performing the procedure. So these data and long-term follow-up data, as well as registry studies, led to the addition of the left atrial appendage occlusion device to a recommendation from the most recent ACC AHA guidelines for AFib. For patients with AFib, a high stroke risk of a CHA2DS2-VASc greater than 2, and a contraindication to long-term oral anticoagulation. So complications to be aware of at the time of the procedure are listed here. One of the major complications that I already alluded to was pericardial effusion and tamponade, which is why it is recommended to get a surface echo prior to discharge in all patients to rule this out. Other complications have to do with vascular access and the device itself. This chart itself was taken from the SCI and HRS consensus guidelines regarding left atrial occlusion devices. And then the post-procedural complications are also listed here. I'll focus on two main ones later in this presentation. One is peri-device leak, and the other is device-related thrombus, as our patient had earlier. So the typical duration of hospitalization for left atrial appendage closure has been at least an overnight stay for observation. However, this is data from a large registry, the National Readmission Database, that there really were not differences between outcomes in same-day discharge versus the next day discharge after procedure. So that may be something that is feasible down the road. So there are three main time points that surveillance imaging can or may be done after left atrial appendage occlusion device placement. One, as I mentioned, is the surface echo before discharge to rule out pericardial effusion. The protocol also states that follow-up imaging should be done at 45 days via either TEE or cardiac CT to look for device-related thrombus or peri-device leak. Some places advocate for 1-year follow-up as well, and you'll see why later. But this is not required, and it's not necessarily as common. So who should not get a left atrial occlusion device? So as you'll see in a second, they have to be able to tolerate short-term anticoagulation or antiplatelet therapies in order to get the device. They cannot have another indication for anticoagulation, just there's not data for this population. And same with patients with valvular AFib. And then finally, they have to have anatomy that's conducive to percutaneous devices. There are certain features of the left atrial appendage that make them not conducive for percutaneous device placement that can be seen on CT or TE. Additionally, the presence of a left atrial appendage thrombus at the time of device placement is a contraindication for placement. So now I'll talk about antithrombotic therapy. So the rationale for antithrombotic therapy is to prevent device-related thrombus during the process of endothelialization. As you can see pictured here, this is from a dog model, but this shows the device completely endothelialized into the left atrium itself. In vitro studies show that this process takes typically between 30 and 90 days. There are ongoing studies to elucidate the mechanism, whether it's primarily the coagulation cascade versus primarily platelet activity. It hasn't been fully cleared up yet, but the main issue is balancing ischemic concerns and bleeding risk in patients that are mostly high risk for bleeding. So the initial trials that allowed for the FDA approving the device used this regimen where patients were given warfarin and aspirin for 45 days. If there is no left atrial appendage leak, then they were transitioned to dual antiplatelet therapy to complete 6 months. And then after that, they were on aspirin monotherapy. Since then, there has been data supporting the use of DOACs rather than warfarin for this regimen, which is in line with increasing use of DOACs for routine use in AFib. Additionally, dual antiplatelet has emerged as an alternative to this regimen, mainly based on usage in Europe, usually from PFO closure devices, and that's actually probably more commonly used in Europe as a post-procedural regimen. And the majority of the data on these different regimen is derived from registry data and observational studies, and thus far there hasn't really been a clear pattern identified. This slide shows major studies and the regimens that were used there. There's some thought that dual antiplatelet could reduce bleeding risk, but may come at the cost of a higher device-related thrombus rates, but this hasn't necessarily held up in true propensity matched data. So one of the earlier studies to compare dual antiplatelet versus oral anticoagulation was a study from 2019. It was a meta-analysis of data for the major Watchman trials, so the PROTECT, PREVAIL, and the CAP trials, which are the follow-up data from those trials, the ASAP trial, and the Evolution, that's the real-world registry data from the Watchman. They propensity matched patients that were receiving primarily oral anticoagulation. 95% of that at the time were warfarin, and 5% were other oral anticoagulations. And interestingly, 92% of these patients also received aspirin for antiplatelet therapy. And then they matched them with patients receiving dual antiplatelet agents. Only 91% of those patients were actually on dual antiplatelet, and there were 9% that were receiving single antiplatelet agents. And they found that there was no difference between the groups in ischemic stroke or bleeding endpoints. However, there was a significantly more device-related thrombus in the antiplatelet group, and this did hold up after excluding the patients who were only on single antiplatelet agents. So then in 2023, there was a retrospective study of data from the NCDR registry of Watchman Flex devices that were done in 2020 to 2021, who were on the 3 major FDA-approved regimens. So they propensity matched patients on DOAC and aspirin to DAPT, and then they did the same thing with warfarin and aspirin. And they ultimately found no difference between either groups in a composite endpoint of thrombotic and bleeding events and their each individual components. However, they did notice that patients receiving dual antiplatelet had significantly fewer major bleeding events. It's interesting to note here that there was not a difference between the warfarin and aspirin group versus the DAPT group in major bleeding events, despite knowing typically that DOACs carry a lower bleeding risk. Again, these are all registry data, so the conclusions are a little more limiting. So those are the 2 FDA-approved regimens, but off-label use of DOACs is also really, really common. So this was evaluated in another propensity-matched retrospective study, this time across multiple device types. So they used both the Watchman and then older generations of the amulet device as well. And they matched patients on dual antiplatelet with aspirin and clopidogrel and DOACs that were not warfarin. They also looked at ischemic events, DRT, and bleeding. The event rates here were relatively low, but they did show that there was no significant difference in ischemic stroke or non-procedure related bleeding, but there was a trend toward lower bleeding and device-related thrombus in the DOAC group. So after this, in an effort to evaluate the lowest level of antithrombotic therapy possible while maintaining good ischemic outcomes, there are a few investigators that have looked at low dose or half dose DOACs. So a study in 2021 performed a prospective non-randomized trial of Watchman devices from 2014 to 2020. The regimen was up to the discretion of the performing physician, but was either a DOAC plus aspirin or a half-dose DOAC with aspirin for the first 45 days. The doses used were apixaban 2.5 and rivaroxaban 10 for the half dose group. And there were 500 patients total in this study. And they did find that the half-dose DOAC significantly reduced DRT, thrombotic events, and major bleeding, as well as a composite endpoint of all of those outcomes compared to the standard full-dose DOAC. This half-dose strategy was also studied in a much smaller but randomized Atrial trial that came out last year from Europe. They randomized patients to dual antiplatelet therapy versus just low-dose DOAC without aspirin. And they also found there was a significant reduction in bleeding, device-related thrombus, and a composite endpoint that also included ischemic stroke amongst the half-dose strategy. So lastly, the table I have here is a summary of a few more studies based on registry data or data taken from the newer device trials. The two things I wanted to point out here is one, that there's a large registry data by Freeman from 2022 that had a decent proportion of patients on DOACs only at discharge, and they appeared to, at least, so this is all just registry data, but they appeared to have comparable ischemic risks, but lower risks of bleeding. And also note that there are some studies that included patients on single antiplatelet therapy as well, but the rates of device-related thrombus and stroke tend to be higher in those groups. So there are numerous ongoing randomized control trials in larger numbers that are directly comparing some of these regimen, including dual antiplatelet versus single antiplatelet therapy, and larger trials evaluating a low-dose DOAC regimen. So the bottom line is there's no consensus on the best antithrombotic regimen immediately after left atrial appendage occlusion. There are three options that are actually approved for the device by the FDA. Either warfarin or DOAC plus aspirin for the first 45 days, followed by dual antiplatelet until 6 months, or you can just be on dual antiplatelet for the first 6 months. However, continuation of DOAC without the aspirin is probably reasonable and likely reduces bleeding risk. In the future, there may be new options such as a reduced dose DOAC or single antiplatelet therapy. So now I'll talk about a few complications. The first one is device-related thrombus, as our patient earlier had. So the incidence is variable across studies, likely owing to the variability in definition as well as variability in reporting and surveillance imaging, but it appears to be between about 2 and 5%. Predicting the timing of device-related thrombus is really difficult. As mentioned earlier, the rationale for the 45-day intensive antithrombotic therapy from earlier studies was due to the timing of endothelialization. However, from this graph, which takes data from a lot of different registry studies, the timing is extremely variable. It looks like, over half of patients had device-related thrombus after that really the 45-day, but the 90-day follow-up, and then the other half had them before. So really the risk can be super variable. There may be a difference between the type of device and the timing of device-related thrombus. So in the Amulet IDU trial, which is the trial that got the Amulet device approved, they found that in Amulet patients, the majority of device-related thrombus occurred before 45 days, whereas in Watchman patients, the majority occurred after 45 days. So multiple studies have evaluated predictors of device-related thrombus, and they include anatomical factors of the left atrial appendage itself, as well as procedural characteristics, such as the distance between the device itself and the left atrial appendage orifice, as well as just general ischemic risk factors amongst patients. So the diagnosis, as I kind of mentioned earlier, can be made on either CT or TE. As you can see the images here, they're generally viewed as having equal sensitivity for the detection of device-related thrombus. So based on retrospective data from the PROTECT trial, the definition of DRT is proposed here based on TE findings of the following characteristics. So it's an echo density on the atrial aspect of the device that is not explained by imaging artifact. It's inconsistent with normal healing or device incorporation. You can see it in multiple TE planes. It's touching the device and has independent motion. And the more factors that you have, the more likely that the possible thrombus is actually a device-related thrombus. So on CT, the diagnosis is typically made by the detection of hypoattenuated thickening on the atrial device surface. So this diagram and the flowchart on the following page are from a position statement that was published in JACC Cardiovascular Interventions. So this shows the appearance of hypoattenuated thickening on CT. So low grade hat, either 0 or 1, shows either no hypoattenuated thickening or a smooth thin lining that is typically less than 3 millimeters and is considered normal endothelialization. High grade or grade 2 to 3 is more thickened or irregular and is considered to be consistent with device-related thrombus. And as you can see on this proposed management algorithm from the same consensus statement, that high-grade hypoattenuated thickening is recommended to be treated as device-related thrombus. So the theoretical risk of device-related thrombus is ischemic stroke and thromboembolic risk. However, this relationship has been kind of inconsistent in the literature. So these three charts come from a meta-analysis by Al-Khoury in 2022. The next one is an analysis of the 4 major initial device trials, and the last one is a large registry data, and they all clearly show a relationship between device-related thrombus and ischemic events. However, this data comes from the real-world registry of the Watchman devices, and then the second chart comes from the Amulet IDE trial, and they show no significant association between device-related thrombus. However, given the conflicting data and the theoretical risk, it's generally considered that device-related thrombus does at least increase risk somewhat and should be treated as such. It is also worth noting that the majority of patients with device-related thrombus don't actually have ischemic stroke. So in the Watchman studies, 75% of patients with a diagnosed device-related thrombus did not have a stroke, and the Amulet trials, 95% of patients with device-related thrombus did not have strokes. So management of device-related thrombus is typically intensification of antithrombotic therapy with follow-up imaging to ensure resolution. Either continuation of anticoagulation for a longer time period or switch dual antiplatelet therapy to anticoagulation. And this is all outlined in the SKY HRS consensus statement from 2023. And usually people do follow-up imaging at 6-week to 3-month intervals to ensure resolution. The overall long-term management is not entirely clear just because of a lack of data. So the last complication I'll talk about is peri-device leak. The diagnosis of peri-device leak is made if there is a residual communication between the left atrial appendage and the left atrium. Usually greater than 5 millimeters is definitely considered significant, but a lot of studies include 3 millimeters as well. And it's generally considered that anything greater than 3 to 5 millimeters is a significant peri-device leak. So as you can imagine, the incidence of peri-device leak is variable across studies, also likely owing to the variable definition of peri-device leak. Some use just really any leak. Some say that it has to be significant. And as you can see here, that the incidence varied from less than 10% to over half of patients enrolled having some form of peri-device leak. This table here lists risk factors for peri-device leak, and similar to device-related thrombus, they're mostly anatomical, different left atrial appendage anatomy, as well as procedural risk factors, and then overall ischemic risk for the patient. The risk of peri-device leak is mainly ischemic events like device-related thrombus. And as you can see here in the major Watchman trials and Amulet trials, as well as the National Registry, their patients with peri-device leak had significantly higher rates of ischemic events. The good news is that a good proportion of peri-device leak may actually improve or regress on their own. So 2 studies looked at the temporal evolution of peri-device leak. The first one followed patients for an average of 189 days. And as you can see to the table on the right, 77% of all patients with peri-device leak, really any level of peri-device leak at 45 days, had regression of their peri-device leak. And this majority effect persisted across all leak sizes from 0 to less than 3 millimeters, even to greater than 5 millimeters. And importantly, that over half, 53% of all patients that had peri-device leak had complete resolution of their leak. And then this other study looked specifically at severe peri-device leak, which was defined as greater than 5 millimeters. This sample size was low, but they did find that 62% of amulet patients and 42% of Watchman patients had regression of their peri-device leak at 18 months. So the treatment for peri-device leak is generally the same as device-related thrombus, which is to continue oral anticoagulation until the leak is occluded and obtain follow-up imaging. However, there are several procedures available that in specific circumstances, including an additional left atrial appendage occlusion device, depending on the anatomy. There are certain plugs and occluders available. You can have embolic coils and then even radiofrequency ablation. So this algorithm for management of peri-device leak comes from another JACC state-of-the-art review from 2023 that shows the management of peri-device leak by size and mechanism. And so it's using the significant leak as greater than 3 to 5 millimeters. So really anything above 3 millimeters should consider treatment. And then there are certain types of device leak, some mechanisms and sizes of peri-device leak that are more amenable and favorable to undergo closure. So ultimately, as evidenced by this statement from the SCI HRS consensus statement, the best way to treat peri-device leaks is to minimize them as much as possible at the time of implantation. So to summarize, left atrial appendage occlusion devices are an alternative for stroke prevention in patients with AFib who have a contraindication to oral anticoagulation. The best candidates for left atrial appendage occlusion devices are those who can tolerate a short course of antithrombotic therapy. There are several options for antithrombotic therapy after a left atrial occlusion closure, although there's no consensus on which one is better, and this is a changing landscape. Follow-up imaging to monitor for device-related thrombus and peri-device leak should occur at 45 days, and then the optional 1-year follow-up with either CT or TEE. And then if a peri-device leak or device-related thrombus is detected, you should intensify antithrombotic therapy, and the patient should undergo interval imaging in 6 to 12 weeks. So I'd like to thank Dr. Kumar and Dr. Westerman for helping me prepare these slides. And this is a picture of my dog. And so thank you for your time, and I'll take any questions.
Thanks, Rachel. This is Neil Dickert. I have a
Hey.
quick question. I'm just curious about your thoughts or others on this. We focus this procedure on people who have a high risk associated with anticoagulation. I'm curious whether there's any discussions of potentially kind of the other group of patients who in theory could benefit from this, which are people who may not have strong contraindications for anticoagulation, but are actually relatively healthy people who would rather not take it, but are going to be on it for a very long time, right? So obviously the risk of anticoagulation is kind of cumulative over time. If you've got young patients, is there any thought about exploring the kind of wider population of kind of lower risk patients who might be on anticoagulation for a very long time, but who would rather not take anticoagulation? Just curious whether that's been explored.
Yeah, I think, and I haven't followed up where this data is right now, but there's a the Champion trial is currently looking, or was at least last time I checked, was looking at patients without a contraindication or lower risk of bleeding for using a left atrial occlusion device kind of upfront. I'm not sure where that is. If anyone else knows, happy to field to them. But I do know that was in process, at least when I first started investigating the topic.
Rachel, Robbie Williams, good talk. I missed the first few minutes. Hopefully you didn't cover this then, but this came up this week. Any thoughts or anything you come across in terms of patient who's had a Watchman device for several years and it's been imaged and its position is good, comes in with recurrent AFib needing a cardioversion, not anticoagulated. sort of thoughts regarding pre-cardioversion TE in a patient like that.
Yeah, so I didn't have a slide on this, but I have also been in this situation and have looked it up. There, as you can imagine, is not really consensus on it. And similarly, there's not a consensus on, so if it's a Watchman or if it was a surgical clip, which I didn't include in this just because, we don't do those, but that there was a study that looked at, so bottom line, there's not a consensus on what the right thing is to do. There was a study, I think last year, that looked at like kind of just like common practices at like 2 hospitals, and it was super variable. It was something like 15% of providers didn't clear the left atrial appendage before cardioversion, and then like 20% didn't put people back on anticoagulation afterwards. So there's people doing variable things, but it's generally considered, as you kind of mentioned, like the farther out that you get from the device placement, probably the safe, and that's been images, probably the safer it is to not clear the left atrial appendage, if that's a concern, just because the higher likelihood that it's been endothelialized. But the other thing to think about is that, and I forgot the number, but it's something like only like 90% of thrombi come from the left atrial appendage itself. And so there's still some percentage that could come from the left atrium. And so the risk of stroke is still there. So moral of the story, I'm not, there doesn't seem to be a consensus on whether to clear the appendage first and then also to put them on anticoagulation after.
Yeah, I agree. That was sort of my impression as well, is that it's just there's a lack of data that would support safely cardioverting someone. Yeah, you're right. I mean, certainly within the first year of device, it's sort of a no-brainer. But these like long patients that have had the device, now we're seeing more and more of these patients have had them for years. Until there's a study out there that shows that this is safe, we're probably compelled, for someone who has been on anticoagulation. I mean, I would probably, as an echocardiographer, but I would probably lean towards doing it, unless there's, some, urgency or contraindication to TE. I'd probably lean that way, just given the lack of data supporting not doing it.
And I think that the other kind of disappointing thing too is that there's not data like for surgical clipping, which generally like obliterates the left atrial appendage. There's not data for that either, which is also a little disappointing. I know you can't necessarily extrapolate it, but would like that as well.
Rachel, this is Stacy Westerman. That was really great. Thank you for presenting that. As far as you brought up the Champion AF trial, which, that goes to, putting the Watchman in patients who do not have contraindication. And that's I think it's a 3-year follow-up. And I think that it stopped enrolling probably about 18 months ago. So hopefully we'll get maybe interim data that'll come out sort of soon. The rate of leak of about 20%, I think, is concerning, and knowing that it is associated with poor outcomes. So I think it's going to be tough if we do start seeing the Watchman sort of unleashed on a population of people who don't have a great reason for it. I mean, most people do fine, but if you start expanding the indication, we'll have to be really careful about that outcome. And we're enrolling in a trial called REACT AF, which is looking at anticoagulation just for 30 days after an episode of AFib as detected by smartwatch. And so there might be more sort of leniency and use of long-term anticoagulation in the future, I hope, based on data that comes out. And that might be the answer to these people who are like 65 and otherwise healthy, maybe hypertension that you're putting on for, 20 plus years.
Hi, this is Shannon Walker. I'm one of the Grady attendings, and I just wanted to respond to a comment earlier, just for food for thought for us all, of just, in this question of healthy younger individuals. I think it's interesting to take into consideration the 20% leak, but I will say I think there's a number of patients that don't actually take the DOACs that we give them and that we see come in for strokes, who are on DOACs, or when I'm in clinic and I see patients who are on apixaban, the first question I ask them is, how frequently do you take your medications? Once or twice a day? about 30% of them say once a day, actually. So I wonder if there was a head-to-head trial of the device versus DOAC in all comers, just knowing that some of these people might not actually be taking their anticoagulation, what the outcomes of that study would be.
Rachel, this is Matt Topol over at Decatur, and I don't know if you or Stacy or anybody else knows. I feel like at some point I heard regarding the leak data and kind of the much higher than expected leak data probably has to do with, you know, like you said, the variation in left atrial appendage anatomy. I feel like at some point people were talking about 3D printing or imaging to better plan for and adapt to different appendage morphologies. Is there anything going on in that space to try to lower the amount of leak?
I didn't see anything, Dr. Westerman, do you know?
Yeah, Matt, I don't know anything about that. I mean, you know, I only know the ones that I implant, and so other implanters, if they're on the call, might have other thoughts. But you know, sometimes you put it in and it looks great, and then there's leak afterwards because the shape changes as time goes on, the way it endothelializes. I don't know that. I mean, the one thing that 3D imaging might show is perhaps whether an amulet versus a Watchman might close it better. But there's some things you just can't anticipate. And Joe Sia has looked at our data, and it's really hard to predict what device, you know, what shape appendages are going to have leaks. It just settles differently. And I don't know that even 3D printing, which I think is a really cool idea, I'm not sure that that would really help solve anything. I mean, some might be technique and sort of, you know, conscientiousness, but some is you just can't really avoid, has been my experience.
So this is Gautam Kumar. There is good data on 3D printing. Actually, there's a number of different people who are doing 3D printing. However, you know, whether that translates to outcomes or not still remains to be seen. There's a group at Georgia Tech who has done 3D printing of LAAs. We have messed around with the idea of doing it, but and probably we should start doing it. We still haven't gotten around to it just yet. Our issue was we hadn't gotten pre-procedure CTAs for a lot of these, so we were using TE for guidance. That makes it hard for 3D printing. But if you're getting a full data set with cardiac CTA, this would be something that would be easy to reconstruct from the cardiac CTA. And there are groups doing it. There's a group in Orlando with who are building, who have actually partnered with the 3D printing company RICOH, RICOH, and they're actually doing 3D printing models of the left atrial appendage as well. So there's individual pockets of places that I'm aware of that are doing this, but how that translates then to an outcome or how a device is going to sit or procedural guidance, that part of it is still unclear.
I think Dr. Coley had to leave. So are there any other questions? If not, I may end the call.
The preceding program is copyrighted by Emory University.